Hi everyone, I'm Amaya and I've created this video as a part of my QIP on improving laxative prescribing in general surgery. In this video, I will go over different types of laxatives and different situations you can use them in, and I hope you find this useful. Constipation is really common in surgical patients, and while it might seem like a minor issue, it can be often overlooked and can cause a significant amount of discomfort for patients or even delay patient discharges. It's really important to remember that laxatives are not one size fits all, and as F1s, we prescribe a lot of laxatives. And I remember when I was on general surgery as an F1, I was only really prescribing Movicol without thinking about the cause of the constipation. So it's important to assess, is the patient constipated because of immobility, or do they have reduced oral intake, or is it because of the type of surgery they've had, or are they on opiates? And it's also important to remember the things you should use laxatives cautiously in, or that they're contraindicated in. This includes bowel perforation, ileus, bowel obstruction, bowel anastomosis, acute diverticulitis, and if you're suspecting there is a collection in the bowel. If you're ever unsure, always remember to check with a senior. I found that knowing how various laxatives work were really helpful when prescribing them in different scenarios, because I understood why I was prescribing that specific laxative for that patient. So we'll first discuss bulk-forming laxatives, which are soluble fibres which retain lots of fluid and increases the fecal mass, and this then triggers peristalsis. These laxatives take a bit longer to work, and so we don't commonly use them in hospital settings or in acute settings. And they also require patients to drink plenty of fluid, and it should be avoided in patients with reduced oral intake or if the patients are quite frail, as this means the patients aren't drinking enough water. And because of this could actually worsen someone's constipation if they're not drinking enough. This kind of laxative is great for someone who's drinking plenty of water and mobilizing well. An example of a bulk-forming laxative is fibrogel, also known as isoflagella husk. Osmotics are another really common type of laxative we use in hospital settings. It works by drawing in lots of water into the bowel from the body, and this extra fluid softens the stool and causes some bowel distension, which then triggers peristalsis. It can take up to 2 to 3 days for it to work, and compared to stimulant laxatives, they act a bit more gently and can cause less cramping. However, to be aware of, lactulose is a synthetic sugar and it gets broken down by the gut bacteria, and this process causes some gas to be released, and in some patients this can cause bloating and some discomfort. Osmotics work really well in opioid-induced constipation when used alongside a stimulant, and it's a great first line in an acute hospital setting, and particularly in frail and older patients who have reduced oral intake. Examples of osmotics include macrogol, lactulose, and even glycerol suppositories or phosphate enemas. Stimulant laxatives are another really common type of laxative we can use, and they essentially work by stimulating the enteric nerves, which triggers peristalsis, and this also increases water and electrolyte secretion into the bowel and also reduces water absorption from the bowel, which all works together really nicely to increase the bulk of the stool and to keep it moving along the bowel. They're really effective when there's slow motility, such as when we use opioids, and they work relatively quickly compared to other types of laxatives. However, this means it can cause cramping. Stimulants aren't recommended to be used long term because patients can develop a tolerance, meaning they will need to use higher and higher doses the longer they use. And examples of stimulants include senna and bisacodyl. So this is a great laxative to be used in a short-term setting or an acute setting. And lastly, stool softeners, which essentially work by reducing the surface tension of the stool, and this allows oil and water to penetrate the stool much better, and this softens the stool and helps to pass it along the bowel much more smoothly. They're quite gentle, and for severe cases of constipation or opioid-induced constipation, a stool softener alone might not be effective, and they also take a little bit longer to work, 1 to 3 days. And an example of this is Docusate. And lastly, we'll discuss opioid-induced constipation. So a lot of our surgical patients are on high-dose opioids. This includes post-op or rib fracture patients. And what opioids does is it reduces peristalsis of the bowel, and this also increases fluid absorption from the stool. And this essentially creates slow-moving hard stool, so when patients are on opioids, it significantly increases their constipation. So we should always be prophylactically prescribing laxatives when they're on opioids. And I always inform patients that I've prescribed the laxative on the regular side, and if they're having any diarrhea or any side effects, just to let us know, and then we can titrate the dose. Because I often found that when I was putting it on the PRN side, it often wasn't being given and patients get constipated. It's really also important to remember that for opioid-induced constipation specifically, guidelines suggest using a combination of a stimulant and an osmotic, such as Movicol and Senna together, rather than just one type of laxative, because this combination helps to keep the bowel moving more effectively. This is a poster I've created as a part of my QIP as a quick reference guide for F1s, so please feel free to take a screenshot if you think this would be helpful, and there should be a copy in the doctor's office in general surgery as well. So on the top left hand corner, I've just summarised all the different types of laxatives we discussed in this video, and also has different examples and their dosing as well. Going onto the table, it just summarises what to prescribe for various situations, such as drug-induced, acute chronic constipation, and also fecal impaction. So going on to drug-induced, it's important to avoid bulk-forming laxatives and to remember to prescribe a combination of a stimulant and an osmotic, and if that's not effective, then not being afraid to add a softener as well. I've included naloxegol, which is an opioid antagonist. However, as an F1, I wouldn't prescribe this without specialist input. And for acute and chronic constipation, important to remember not to prescribe bulk-forming laxatives in elderly patients or frail patients with reduced oral intake. And in an acute setting, I would just go for an osmotic laxative, as bulk-forming laxatives can take a little while to work as well, and if that's not effective, then going on to a stimulant. And if someone is having diarrhea when they're on a laxative, it's really important to consider fecal impaction and overflow diarrhea. So make sure to always do a PR exam, and if they have hard stool in the PR exam, then I've just included what to prescribe, and if they have soft stool, then the prescribing is slightly different, as mentioned here. And this also highlights the importance of encouraging patients to increase their fluid intake, increase their fibre with their meals, and also mobilise as much as they can, as all of these can be achieved within a hospital setting as well. So just to summarise some of the key points we've discussed, first point is always remember to prescribe laxatives when prescribing opioids prophylactically, because opioids significantly increases the risk of constipation, and just inform patients that you've prescribed the laxatives and to let us know if they're having any side effects such as diarrhea. Always remember to use a stimulant with an osmotic in opioid-induced constipation, and just remember to encourage lifestyle factors such as increasing their hydration, increasing fibre, or trying to mobilise, and these can be achieved in a hospital setting. And don't be afraid to use a combination of laxatives. If one type of laxative isn't effective, such as Movicol, rather than increasing the dose, you can consider adding another type of laxative, as they work all differently and can be really effective when used in combination. So yeah, thank you so much for listening. I hope you found this video helpful, and please don't hesitate to email me any questions. Thank you so much.